Craig, I think it's now officially recording. Good to go.
All right, thank you, Chicky. I wanted to welcome everybody to the April 2022 Health Insurance Advisory Marketplace Advisory Committee. And since most of the members are relatively new, at least within the last couple of years, we typically start with a roll call. But what we thought we'd do instead is do a round of introductions so everybody can get to know each other a little bit better. So with that, we're asking you just to, Chicky will mention your name. So let us know if you have a preferred name, mention your preferred pronouns, your company affiliation, and also any background information you'd like to share. With that, I'll hand it over to you, Chicky.
All right. Good morning, everybody, and I will kick off for the staff and pass it off to the committee here. I'm Chicky Flowers. I'm the administrator of Oregon Health Insurance Marketplace. My preferred pronouns are she, her, and hers. And my background with the Marketplace Advisory Committee is I am fortunate enough to be the administrator of the Health Insurance Marketplace. So not officially a member, but one of the staff members for the committee. And Craig, you're next, please.
Great. So I'm Craig Anderson. You can refer to me with he, him, and his pronouns. And I've been affiliated, or I'm affiliated with Moda Health in Portland, Oregon. And I've served on the Marketplace Advisory Committee since 2018. And just by way of background, I've been with Moda Health for 21 years. And during that time, I've worked in the individual market in various capacities during that time. And even though the individual market is relatively small in the scheme of things, it's a really important market. It serves people who don't qualify for Medicaid, of course, or don't have employer coverage. So it's always been something that I've had personal interest in and been interested in making sure it's been a stable market and a sustainable market too. And one of the reasons I've been, I've wanted to serve on the HIMAC. So thank you.
Thank you, Craig. And Gladys, do we have you here today?
Yes, I'm right here. Good morning, everybody. Gladys Boutwell, Insurance by Design. I'm an insurance broker since 2013. Started on the individual market, then moved into small business, those that have less than 50 employees. And I just want to stay up to date and see what we can do to continue helping Oregon continue with most appropriate coverage for our residents.
Thank you, Gladys. Ron Gallinet.
Good morning, Ron Gallinet. I am an insurance broker in Bend. I handle individual, Medicare, and mostly small group. I've had experience. I was on the Oregon Educators Benefit Board, or OEB, for 12 years, Ben Lapine School Board for 14 years. Currently serve on FDAB, but my business, when I have time, if you will, is focused on medical insurance in Oregon.
Thank you, Ron. Maribeth Guarino.
Good morning. My name is Maribeth Guarino. I use she, her pronouns. I'm the healthcare advocate with OSPERG, which is a consumer advocacy organization. I joined the HIMAC earlier this year, but I've worked with a couple folks on this committee and in DFR about consumer costs around insurance and healthcare over the last couple of years, including HIMAC costs. So just want to continue to be that voice for consumers here.
Thank you, Maribeth. Paul Harmon.
Hello, so Paul Harmon, he, him, his pronouns. I'm affiliated with Regents Blue Cross Blue Shield of Oregon, where I've worked on mostly the ACA lines of business, so individual and those small employers for most of my time there. Oddly similar to Craig, 21 years with Regents, and brand new to the board and just looking forward to working on the individual market with a new perspective.
Thank you, Paul, and welcome. Lindsay Hopper.
Hey, good morning, everyone. My name is Lindsay Hopper. I use she, her pronouns. I have been with Pacific Source coming up on 7 years. By background, I'm a healthcare lawyer and also worked mostly in public health. For Pacific Source, I'm in the commercial and the Medicare and the Medicaid space. And I am new to the HIMAC, but looking forward to better serving all of our members and all Oregonians.
Thank you, Lindsay. Kathleen, Jonathan? Ines Kemper?
Hello, my name is Ines Kemper, she, her. I'm a small business owner and low-income person who has been using the ACA since its inception. So I'm hoping to bring the voice of the end user to this group. And I look forward to serving all Oregonians.
Thank you, Ines. Lindsay Shirahama?
Hello, everyone. I'm Lindsay Shirahama, she, her, hers. I've been on with the HIMAC for just over a year now, and I work with Project Access now. So it's a Portland-based healthcare nonprofit, and I'm the manager of the Premium Assistance Program. So we pay for people's health insurance when they are struggling to make those payments. And I've been in helping people do enrollments for Oregon Health Plan for the health insurance marketplace for 7 years now. And that's where my passion is, I guess, to help people get access to care and help them understand how to actually use that health insurance once they are on it. But thank you.
Holly Sorensen?
Good morning, everybody. I'm Holly Sorensen, she, her pronouns. I'm affiliated with Northeast Oregon Network, which is a community partner with the marketplace. And since about 2014, I've been helping consumers with Medicaid and the marketplace. And I've also been supporting community health worker trainings since we are also a training program. And so I bring that background as well. I'm really looking forward to getting to know all of you and just having a seat at this table. This is my first meeting as a member. Thank you.
Andrew Stolfi?
Thanks, Chicky. Good morning, everyone. I'm Andrew Stolfi, use he, him pronouns. I'm the director of the state's Department of Consumer and Business Services and the State Insurance Commissioner. I've been involved with this committee and its work for a little over 4 years when I became insurance commissioner, and have had a formal seat on the committee for a little over 2 years after I became the CBS director. I've been an insurance regulator for almost 14 years, I think, in a couple states. So I was with the Illinois Department of Insurance for a while until I started, worked internationally on insurance regulatory matters, and now very happy to be in Oregon and to be on this committee. Thanks.
Thank you, Andrew. Sakinai?
Just 1 second. Good morning, everyone. This is up. Can you see me? Okay. Good morning, everyone. Good morning, Shiki. Can you hear me? Yeah. This is Tipriyaporn Sakinai. I am a small business owner. I owned Shaheen Limited Associate, and just like Paul and Craig, I've been doing this for 21 years. Book of business are individual health insurance, employee benefits, life insurance, and some part of financial services, including Medicare. So I'm brand new to HIMAC, and I share something in common with everyone. Just I want to hoping that we can make a good coverage plan for the consumers and make them have a better access. Thank you.
Thank you, Drew Tarab?
Good morning, everyone. My name is Andrew Tarab, but I go by Drew. My preferred pronouns are he and him. I lead the financial and actuarial analytics at Providence Health Plans, and have been there just a little under 9 years now. And before my move to the left coast, I was deeply involved in state of Massachusetts individual programs what was lovingly referred to as Romney Care, in the foundation of the connector network, and then the more commercialized individual market. So they were rolled out through both the Medicaid programs and then the commercial carriers.
Nishoba Temperley.
Hello, everybody. I'm Nishoba Temperley, he, him, his pronouns. I'm with the Cascade AIDS Project. I have been assisting individuals in enrollments for about 7 years, and now I oversee, manage a team of benefits navigators, primarily enrollment assistance, care coordination, some specialty referral in the Portland metro area, predominantly within the LGBTQ populations. It's a first meeting. Thanks, everybody.
Thank you, Nishoba, and that rounds out our current roster of committee members. I'd also like to bring up to the camera Victor Garcia.
Morning, Victor Garcia. I'm Operations Development Specialist with the Marketplace. Do some project management and other duties as assigned. Present a lot of information to the committee about things that we're working on right now, and provide additional context wherever it's needed from the sort of state worker side of things or the staff side of things when needed.
Thank you, and Victor, with his other duties as assigned, one of his new duties starting this year will be your committee liaison. And your other committee staff member is Dawn Shaw.
Hi. I'm trying to navigate new ways, our new setup with this. So I don't know if I'm on camera or not. I'm Dawn Shaw, and I'm the office support specialist for the Marketplace, and I'm happy to be here with everyone.
Thank you, Dawn and Craig. That rounds out introductions for today.
Thank you for going through that. I also want to mention last month, Chicky and I were able to meet with the newer members, and I want to thank everybody for making time to do that. It was great to get to know you a little bit better and talk about some of the priorities that we'll be working on, which we'll cover later in the agenda this morning, but just wanted to say thanks again for making time to do that. So I think we'll move on to the next order of business. And if you can forward the slides. So since we are relatively new, we thought it was important to cover some ground rules for these meetings. And one thing that became crystal clear to me when we were doing these introductions last month is that we do have a diverse group of people who represent the different constituents of the marketplace, between insurance agents and public advocates and consumers. So what we thought was important was just to make sure everyone had a voice on this committee. So the Marketplace and the HIMAC is committed to a safe and inclusive meeting setting for all attendees. So we just want to emphasize that. And really what that means is just we recognize that the committee does represent a number of different backgrounds, and we want to make sure that all the voices are heard by people, and that is done in an inclusive and in a respectful way. Also, I just want to say, because people are relatively new, not everybody has 21 years of experience in this business. Please, if you hear something that you're not that familiar with, even if you think you probably should be familiar with, please stop us and ask questions there. No silly questions, no reason that you shouldn't interject with any questions that you might have. So just to round this part out, if you do feel like you're subject to unacceptable behavior or you witness anything, you can always contact Chicky. I can say during my few years here, I've never seen anything that comes close to this, but we do think it's very important to make sure that this committee is a safe and inclusive place. So next slide, please. So in terms of just some additional protocols, we ask that you stay on camera to the extent you're comfortable with that, but please mute your speaker when you're off camera. Also, if you have a question, the best way to do that is to raise your hand. We'll monitor that and get to you in the order that you raise your hand. So that's something we'd like you to do. And of course, if you have any issues with sound, these virtual meetings do have closed captioning featured, so that's available, and you can find that by clicking the more and selecting turn on live captions. So those are the main protocols that I wanted to go over. Any questions about that or conversation? Okay, I guess not. We'll go on to our next topic, which actually I think we are supposed to have Director Allen. Is that right, Chicky?
Not for today. He had to bow out due to a personal, so he will join us in our July meeting instead.
Okay, great. Yeah, and just before we get to this part, again, another thank you to people. We were invited to the Health Policy Board retreat. And so for those of you that made the time to attend part of that, I just want to thank you for making the time. I think it was a really good introductory meeting for us for us to get familiar with the Health Policy Board and the Oregon Health Authority in general. If you are or not aware, the Health Insurance Marketplace Advisory Committee did recently move under the Oregon Health Authority. So I think being invited to that retreat gave us a good sense of the priorities of the Oregon Health Policy Board, also the committee structure and the focus on health equity. So I appreciate having that invitation, and thanks to people who took the time to do that. So Chicky, I'll turn it back to you to talk about the minute approval.
Thank you, Craig. So usually in our meetings, we go through the minutes and go through an approval process. As we mentioned before, we hope to, after a meeting, we send it not too long after that, a week or so after, so that you can review. So between the transition to agencies and our technical difficulties this week, we fully recognize you have not had time to review the minutes from January 2022, our meeting from that time. So I would like to defer this instead to give you all some more time to review the minutes that you will see in your handout packet. And if you are amenable to this, I would like to start a discussion through email to approve it instead about a week from today. So in about 7 days, next Thursday. Does that sound okay to everybody?
Yes.
Yeah, one thing I would just like to highlight about the minutes too, maybe you said this, Chicky, and I just missed it, but Dawn does a great job of getting the minutes out very soon after the meeting. So sometimes with these sorts of meetings that take 3 months between meetings, you see the minutes 3 months later and you don't really recall the conversation. So those do go out very quickly after these meetings, and you do have a chance to see those while your memory is fresh. All right, so should we get to the next topic?
Sounds good. Next slide, please, Dawn. Thank you.
Sure.
Okay. So for those of you, again, maybe some of you were here for our last committee meeting. I've been fortunate enough to attend these for a number of years, and we have Stephanie Kennan, who does an update of federal health policy issues, and they've been, as you could imagine, over the last few years, more or less exciting, depending on what's going on in Washington, D.C. So with that, I'll let you take over from here, Stephanie.
Well, good morning to you all, and thank you very much for having me again. You would think that by late April, Congress would be rocking and rolling and passing legislation. No. They have passed some legislation, some important legislation, but they haven't really haven't figured out how to move forward on some healthcare issues. So I'm going to start with the appropriations process, and you may wonder why you care, but this is the process where money for outreach and funding some of the marketplace functions comes from. Congress passed an appropriations bill to fund the government through September 30th, which is this fiscal year. Because it's an election year and appropriations has become harder and harder to actually get passed, they decided the common thought was that we would pass a continuing resolution through to next year, sometime in September, and let the new Congress do the appropriations process. However, we have the Senate chairman of appropriations, the Senate ranking member of appropriations, and the ranking member on the Senate subcommittee on labor HHS retiring. Two of those are Republicans, one is a Democrat. The two Republicans have convinced their colleagues in the House that they shouldn't retire without one more crack at appropriations. And so the Democrats in the House have said, okay, we'll try. So in June, tentatively, they're going to start working on another appropriations bill. Their timeline is to have that bill on the floor of the House for consideration before the August recess. Now, I've been doing this a really long time, and I don't mean to sound cynical, but I haven't seen appropriations move that fast in the House forever. So it would be great if that actually happened. We'll have to see if that does happen. The Senate will move much slower. And in fact, one of my colleagues who does a great deal of appropriations work said, I really don't expect anything to really take shape until the lame duck session in November. But the reason I'm telling you this now is because a lot of issues will pop up if they truly start working on appropriations. And the Republicans are going to have different priorities than the Democrats, as usual. So it'll be an interesting thing to watch. I want to touch upon next the Build Better Act, Build Back Better Act, because it had a lot of health pieces in it that a lot of people want. It had drug price reform, it had extended premium tax credits, it had some of the Medicaid pieces that people would like to have passed and closing the Medicaid gap, and it fizzled in the Senate because of two Democrats. The health pieces are still alive. They get talked about often. There's a lot of discussion about how to make them skinnier. And then the question of where do you put them? Some of the pieces could move on legislation that is not coming out of the Committee of Jurisdiction for Medicare, Medicaid, and where most of the work has been done on drug price reform in the Senate. That would be Senate Finance Committee. The Senate HELP Committee, Health, Education, Labor, and Pensions Committee, and the House Energy and Commerce Committee are working on what are known as the user fee agreements. There's a series of legislation that essentially are agreements with manufacturers of drugs, both brand and generic, and medical devices that help of how much they will pay as they use the FDA. And these funds actually fund jobs at the FDA. It is must-pass legislation. The Energy and Commerce Committee has about 22 bills that they would like to attach to the user fee legislation. Some of those are in Medicaid, some of those would have to do with drug pricing reform. It is still to be seen if they will be able to do that. But some of these Build Back Better Act pieces, not the tax credits, but some of the health pieces may appear and people may try to attach them to the user fee agreements. As I said, the user fee agreements are must-pass legislation. They really need to be done by the end of September because that's when the current user fee legislation expires and people will lose their jobs and drugs and devices won't get approved and everybody will look bad. So it's also one of those pieces of legislation where it stalls and it looks like it's not going to happen and then it resurrects and then it stalls and then it finally passes. So it'll be a long negotiation process. The Senate is still saying they would like to pass that in a clean way, but if the House attaches legislation, then the Senate's going to want to attach legislation and we'll have to negotiate our way through that. Just a couple of other things I wanted to raise. Provider directories. CMS came out in March and said that no more than 40% of the provider entries in the directories they surveyed had current phone numbers, addresses, specialties, plan affiliations, or information that the provider was accepting new patients. And no more than 73% of the providers reviewed had data in machine readable files that matched the insurer's online provider directory. Why is this important? It's because the No Surprises Act, the legislation passed by Congress about surprise billing, includes extensive new standards for provider directories. And under that law, if a patient uses a provider directory and relies on it, they are held harmless from higher cost sharing if the information was inaccurate. So while that hasn't been implemented yet, CMS is definitely gearing up to tell providers and insurers, you got to get your house in order because we're going to be implementing this other law soon. So there's a lot of concern going on about provider directories. CMS has also renewed its non-enforcement policy concerning grandmothered plans. This has become an annual tradition where CMS extends the non-enforcement policy, meaning they're not going to go after plans that were in existence in 2013 and have been renewed ever since, but don't meet the extensive 2014 ACA requirements. They do meet the 2010 requirements. Advocates really don't like these plans, would like to see them going away. But for a variety of reasons, most of which is that some people are comfortable with these grandmothered plans and they haven't died out yet. CMS is not willing to go after them, even though the law says they should. So we wait every year for this non-enforcement policy renewal to happen. I also want to mention just quickly that CMS has issued new guidance and is having to rethink this No Surprise Billing Act because of a court case in Texas. They have to go back and look at the regulatory language directed at arbitration and what the benchmark is for the arbitration. They issued guidance. They're probably going to have to do a new rule and propose a new rule for that. So just something else to keep in the back of your mind. The last issue I'm going to mention is just the insulin cap. Actually, it's the second to last issue. The insulin cap. The House has passed legislation to cap the cost of insulin. It's unclear what will happen in the Senate. Majority Leader Schumer has said they will vote on it, but right now there are not the votes to pass it because of the way the Senate rules work. They're still trying to work that out. So even though he has repeatedly said, as soon as we come back, and they are in recess this week, we're going to vote on it, I suspect that vote may get shoved off a little bit. The last thing I want to mention is the family glitch fix. You have a longer session on it, so I'm not going to go into gory detail, but I want to give you some context. In the Build Back Better Act, there was a provision that most advocates really liked to fix the family glitch in the premiums. And because Build Back Better stalled and died, the Democrats looked at how they could do something, and they looked to the administration. Part of the problem in the legislative arena was that the fix was very expensive. And that meant it had to be paid for in order to pass. So a lot of money was going towards trying to fix that. Now that the administration has issued a fix to the degree that they can do a fix, it's not perfect. It's not what was in the legislation, but it is a fix. It will help a lot of people. Because they made the change, the budget baseline then changes and the cost gets built in. So if Congress is able to do anything more, let's say in the lame duck session, it's less expensive for them. So it's a little bit of blue smoke and mirrors, but I wanted you to be aware of this because there have been some people who have said that what the administration did doesn't go far enough. They have done everything they possibly can with their authority. Congress needs to do more if we were to do even more on that. Their hang up was the cost. Now the cost is less. And with that, I will end and let you, and if you have any questions, I'm happy to take them.
Thank you, Stephanie. That's a lot of great information. Did you have a hard stop here in a few minutes?
Yes, I do, in about 3 minutes.
Okay, so please, if you have any questions for Stephanie, I think we have time for maybe a couple.
You're still absorbing everything.
Well, while people are thinking, I think the one thing that, from my point of view, is maybe most impactful on the marketplace is the extension of the premium tax credits. And you mentioned, I think, the user fee regulation, but is there any vehicle to get that extended, the premium tax credits?
No, unfortunately, right now there is not. There's some discussion about trying to package that up with a couple of other provisions from the Build Back Better that are somewhat tax related, and trying to move those as a skinny package. But there hasn't been enough momentum. And there are some Democrats who, I'll say right now, this could always change, are not comfortable with extending the premium tax credits. And the administration's been working on them.
Interesting.
The problem being that in the Senate, the margin is so close that you really need everybody, all the Democrats together to counter those who would vote against it. And right now we don't have all the Democrats together.
Stephanie, I have a question. On the provider directory that uses regulated by CMS, is it supposed to be done by 2022? And the provider need to make sure that they are in the network. Is that correct?
Yes. I'm not sure that it's calendar 22. Maybe they may have a little bit more time because CMS is actually pushing them to do additional work, which was not foreseen by the insurers, to make sure that everything is all together. But they're running out of time because essentially once CMS starts to implement the No Surprise Act portion of this, then they really need to have their provider directories all together.
Okay, thank you, Stephanie. I think we're up against time here, so
Thank
we
you.
appreciate it and look forward to your next update.
Thank you very much. Bye-bye.
Okay. Bye. Good. So next we are going to move on to Amy, who will give us an update on the new 150% federal poverty limit special enrollment period. So thanks, Amy.
Hi, everyone. My name is Amy Coven. I think I've met many of you in my time here at the Marketplace, but I am the communications strategist for the Marketplace, and I am going to talk about the new special enrollment period. So Dawn, if you don't mind going to the next slide. So just a little bit of background, because I know we've got some newer faces in the room. A special enrollment period, of course, is a time when folks can shop for health coverage outside of the normal open enrollment period. And so recently, there was a new special enrollment period that started. It was implemented into the Marketplace March 18th fully. However, we really started ramping up our messaging around April 1st, just to make sure we gave them time to get it fully implemented and working for folks. And this special enrollment period is really impactful and available to people who are at or below 150% of the federal poverty level. And so I wanted to make sure, I know that that's kind of ambiguous when we talk about percentages, so I wanted to make sure that you had a representation of what that dollar figure actually meant for different household sizes. The federal poverty level is really based on how many people are in the consumer's tax household, is what's considered for the Marketplace, and then gross, what's called modified adjusted gross income in comparison to that tax household size. So these would be the folks that would be really impacted by this. And Dawn, if you want to go to the next slide. So this special enrollment period is continuous. So a lot of special enrollment periods have a very strict timeline. For example, if you're losing coverage through a job, you have 60 days from the date that coverage ends to shop and enroll in health coverage through the marketplace. But this particular special enrollment period is continuous, which means if someone is at or below that income threshold, they can actually enroll through the marketplace or change their plans if they're already enrolled at any time throughout the year. Yes.
Do you mind if we take questions while you're going here?
Yes, absolutely.
Okay, I think Drew had one.
Did you have a question, Drew?
I do, and it could wait, but since Craig called me out, I'll ask it now. Given the FPL threshold, is the expectation that the number of individuals that would fall into this category relatively low, and that many of them would ultimately qualify for Medicaid?
Yes, that's a really great point, Drew, especially because here in Oregon, we did expand Medicaid under the Affordable Care Act. And so we do anticipate that there is a fairly low percentage of folks that would qualify.
Thank you.
Yeah, absolutely. So again, for those who do qualify, they can take advantage of this at any time. And I'll talk a little bit about why this is important in a minute. But it's important to know that the effective date of coverage would be the first of the month following their enrollment, even if they enroll at the very end of the month. And this special enrollment period is really tied to the provisions within the American Rescue Plan Act that does make coverage a little bit more affordable for folks. So currently, as Stephanie was talking about in her presentation, those provisions are set to end at the end of 2022. So this special enrollment period would also end at the end of 2022. However, if those extra savings provisions are extended under additional legislation, then this special enrollment period would also be extended. So we're definitely watching that very closely for a number of reasons, obviously, but to know if this is going to be extended as well. Dawn, if you want to go to the next slide. So talking a little bit about why this is important, because as Drew, brought up a very good point that there is a very small percentage of the population here in Oregon that will actually qualify. We have heard recently that there has been a number of folks who are currently enrolled in Oregon Health Plan benefits and have experienced some sort of change in circumstances where their income might have gone up or something like that. And maybe the Oregon Health Plan isn't necessarily the best coverage for their needs. Maybe they have a primary care provider or a mental health provider who is not in network with their Oregon Health Plan coverage. And so they really would like to be, within the marketplace. So this special enrollment period actually does give the opportunity for folks to transition from the Oregon Health Plan to the marketplace. Whereas that usually isn't really an option, especially because there is currently a lot of people who are being held on the Oregon Health Plan under what's called the continuous coverage requirement, which is tied to the public health emergency related to COVID-19. And so with that continuous coverage requirement, if someone does experience a life change and they submit that to the Oregon Health Plan, the Oregon Health Plan is actually not going to determine that they're not eligible for coverage anymore. They'll actually hold on to those folks until the public health emergency ends and the Oregon Health Plan does begin that process to redetermine eligibility. So with this special enrollment period being available, and with some additional flexibilities that are being afforded to folks through the marketplace, where you don't have to provide, specific documentation that was required in the past. If someone has experienced a life change where their income is putting them above the income limits, for example, of qualifying for OHP, they could actually cancel their OHP coverage and come over to the marketplace and get financial assistance as long as they meet, obviously, the eligibility criteria for that. So again, this is a really unique opportunity. Typically, we wouldn't tell people, you know, leave Oregon Health Plan and come over to the marketplace because Oregon Health Plan is really great. But we just want to acknowledge that there's a number of circumstances where moving is going to be the best option. And so this special enrollment period is very, very important for those folks. And I think I have another slide, Dawn, if you want to go forward. So I talked a little bit about the timeline of implementation. It was technically available before March 18th. However, it was kind of a manual process where the consumer would apply and they'd be told, you know, you can't shop right now because open enrollment ended, and then they'd go back through and kind of correct that. But since March 18th, the healthcare.gov system has been updated. So if someone goes through and they are within the eligibility criteria to qualify for this, then they will be told in their eligibility notice that they can shop for a plan. Now, it's really important to note that folks do have to meet that income eligibility criteria. If they are above 150% of the federal poverty level, then they would still be told they're not eligible to shop unless they qualify for some other sort of special enrollment period. And I believe I have one more slide. And so here at the marketplace, you know, a large part of what we do is communicate out when changes happen and make sure that folks throughout Oregon really have the opportunity to get health coverage. That's our number one goal, right? And so we are doing a number of different tactics for outreach and communications in regards to this special enrollment period. One of them is very exciting because this is actually pretty new for us. We are doing some direct messaging to folks who have recently been denied OHP benefits. So if somebody had submitted an application since the end of open enrollment and they were told from OHP that they're not actually eligible, then we are actually getting the information from the Oregon Health Plan team so that we can reach out to them directly through email, and then also through postal mail, through traditional old letters. And we have translated those communications into a number of different languages so that we are communicating with folks in the language that they prefer. We also have a social media campaign going on. We've got some organic posts and also some paid advertisement that we're doing on Facebook, Instagram, and Twitter. And that's driving some traffic to our site, which is really exciting. We do also have some Google ads that are running as well. And then we've also produced some RAC cards, which again are translated into multiple different languages. So they're English on one side and then a different language on the other. And we have a communications toolkit, which we have shared with some of our partners. And we're currently kind of revamping it a little bit to match our new color schemes and things, but we do have that available for folks to help share the message of this special enrollment period. And I think that was my last slide, but I'm happy to answer any questions that folks have.
Thank you, Amy. Any questions? Oh, please go ahead.
Good morning, Amy.
Morning.
Yeah, Amy's on the slides of the income and it show annual gross income. What about people who self-employ? Are we still looking into a net income?
So that's a great question. The income guidelines for this haven't changed, so it's going to be the same as how you would report through the marketplace. And so you'll have to forgive me because it's been a little bit since I've gone through the application, but I'm pretty sure that it's the net income for self-employment.
Yeah. And second question is on the life change. Let's say, you know, people who have been approved with OHP and then talking about, let's say, a family of 4, the parents have more income. Will the kid automatically got kicked out from OHP, or they can still able to stay with the OHP?
That's a great question. So right now, because of the continuous coverage requirement, nobody is losing Oregon Health Plan benefits unless you meet like very strict criteria, you know, fraud, things like that. But for the most part, people are not being deemed ineligible for Oregon Health Plan. That being said, and you know, without getting too weedy about like going between programs, because as we all know, it can get a little in the weeds there. What my recommendation would be is that someone works with a professional such as yourself or an assister to really determine what they would qualify for as a family. That way, when they contact the Oregon Health Plan, they can be very specific about who needs to cancel benefits. As we know, children do have a much higher income threshold to qualify for OHP. So in a lot of circumstances, we would not want to cancel those benefits for the kids. We would only want to cancel for the parents. And then the parents could transition over to the marketplace.
Okay, good question. Anything else for Amy? So Amy, maybe in summary, if I'm hearing you correct, I think Drew pointed out probably not a lot of people that would be eligible, but more flexibility to people. Is that sort of the message there?
Yeah, absolutely. We've had a lot of really recent feedback where folks are, you know, needing to transition off of OHP. And so this is granting a little bit more flexibility for those folks, which is really exciting.
Yeah. And I think the other thing about this, particularly this last slide, coverage is out there for Oregonians. It's just a matter of getting the word out and making sure people understand that. So I'm encouraged by seeing that, and we take these opportunities to reach out to more people.
Absolutely. Thank you.
Yeah, thank you. All right, with that, I think we're going to switch now to cable. It's going to tell us about the family glitch fix, which is dogged us for years since the ACA was passed. So excited to hear about this, Cable. Hopefully you're out there. Maybe if you're on mute.
Oh, Cable, if you were on the phone, I think the phone's got muted. So if you hit *6, that should unmute your phone.
Okay, switching to the computer. Can you hear me?
Yes.
All right.
Thanks.
Perfect. Give me just a second to adjust my settings here since I was on the phone and it was not unmuting me. All right. Let me get back to what I was saying. Cable Hogue, implementation analyst and federal liaison for the marketplace. Clearly not tech savvy. So about the family glitch. To give you kind of a high level overview, Don, can you get the rest of that slide to pop up for me? Perfect, thank you. The family glitch is due to the fact that under the current guidelines, affordability for a household with employer-sponsored coverage is only based on the income of the employee and their charge. So as long as that is less than 9.61%, which that percentage point changes annually based on some affordability factors, the entire household is considered affordable, regardless of the portion that spouses and dependents would pay. So they could be paying full price, say 25% of their income, as long as the employee's portion is less than 9.6%, they do not qualify for tax credits. You can go to the next slide, please, Don. The fix that they're well, I sort of went over this too. Next slide. The fix that they're trying to implement or are going to implement changes the assessment to the whole family. So the worker is still looked at 9.6%, but then the spouse and dependents are also included in that. So if their portion of their coverage exceeds that 9.6%, they're effectively considered unaffordable coverage barriers under the new rule, and that would allow them to then purchase through the exchange for the spouse and dependents, not the employee. The employee, as long as their portion was still at that 9.6 or lower threshold, would still be prohibited from receiving tax credits on the marketplace, and likely remain in their coverage at their job. And it does it in two ways. It assesses the whole family for the affordability. If it deems that the spouse and dependent are not on affordable coverage to their employer, then those individuals can shop through the exchange. And then the affordability for tax credits is based on the entire income, but just those family members. And that's how their affordability for tax credits would be determined through the marketplace. Next slide. So they're accepting public comments on this. Those comments are due to the federal rulemaking portal by Monday, June 6th. So if you would like to, present any comments in support or in opposition of the proposed glitch, or bring up any considerations you have from your perspective on what might need to be taken into account, that would be the time to do it. There's going to be a public hearing on June 27th at the ripe early morning time of 7 a.m. for us West Coast folks, because everything's East Coast time when they do these meetings. And finally, healthcare.gov has indicated that they are going to have this operational by open enrollment this fall, so it will be in effect for 2023. That's a pretty good indication that they know with fair certainty what the parameters of this rule are going to be and how it'll be run through the system, because those IT changes are already being worked in and getting ready for their build. So that's about all they've kind of released publicly on this. Does anybody have questions, comments, concerns?
So this is Gladys. What can we do to help move this along? Because this is so important. I mean, I deal with employees that their employers don't cover any percent of the family. So what is there something that we can provide and say, hey, this is what we're seeing, this is how it's affecting families? What's it going to take to help push this through is essentially my question.
I don't think that it's not going to get pushed through, but any public comment that you submit in support is read. And so if you wanted to just, describe the pain you've seen in your consumers with having to deal with this, you could submit it to the public comments as general examples in support of the rule. And so that would help it. Looks like there's a couple more questions out there. I can't see who they're from. I just see a little hand raised.
Ines is next.
Can you define family for the purpose of this legislation?
It's tax household family. So whoever is in your tax filing household would be considered the family. So individual, spouse, dependents, all the usual Affordable Care Act guidelines to the household apply here.
So it's not so much because some companies will take domestic partners, et cetera. It's only taxes.
Well, I mean, as long as you can file your taxes jointly, domestic partnership or not, that shouldn't affect this here.
Okay.
Thank you for that question. Any other questions for Cable on this? Yeah, I think this is going to be an important.
Looks like.
Go ahead. Oh yeah, Lindsay, go ahead.
Thanks. I'm just curious there. So it's going through a public comment session, but is there any question of whether this is going to go through? You also said that the marketplace is planning on this for open enrollment.
I mean, publicly, I guess there's probably a question. I'm not certain. I haven't heard any kind of scuttle that it's not going to get pushed through, but I haven't also heard that, you know, it's written into the concrete wall, if you will. That's part of an executive order to make healthcare more affordable. So unless the comments reveal some considerations that really alter the implementation or accessibility of the rule, I would think it's going to be implemented. And I think that all of the individuals who work behind the scenes believe it's going to be implemented, but it hasn't become official just quite yet.
Thank you. It'd be really nice to see this family glitch not be such an issue.
Yeah, Lindsay, I believe that most changes in regulation, unless they're emergency changes, require a period of public comment. So I wouldn't take that to mean it's more or less likely to go through. It's just a standard process that these things go through from what I understand. We have a question in the chat here too from Drew.
Oh,
you see
so
that?
Are there any cons to implementing this rule? Example, why wouldn't it pass? I guess probably from a budgetary sort of lens from the federal government's point of view, it's going to obviously increase the financial assistance paid out. So there is some budget considerations to be taken into account. As far as cons other than that aspect, I really don't think that anyone believes there are cons to this. I suppose having households in two different types of coverage with maybe two different insurance plans, because many, you know, small business plans aren't offered, you know, simultaneously. But large group, especially, there's a lot of barriers that are not.
Hey, Cable, we're losing your audio.
Hear me now?
Barely.
How about now? I'll stand a little closer to the computer.
Yeah.
Okay. I was just saying that with large group carriers, there's quite a few that aren't on the marketplace in Oregon. So you could have, you know, one person receiving healthcare from one carrier and the rest of the family from another carrier, and, you know, obviously not meeting the same family deductible. And so I suppose from that lens, you could say that's maybe a con. However, you know, given the cost sharing reductions at certain income levels and the wide array of plans folks will be able to choose from on the marketplace, I think that that's muted fairly well. So I can't think of any real like solid cons as to why I wouldn't pass, but you never can tell in this environment, I suppose.
Hey, we're kind of up against the time on this topic, but it looks like it's going to roll through with this public comment period. So maybe we'll have a chance to monitor it as it progresses. So appreciate it. Cable, you get to bring good news to the committee. So we like that. All right. So we have a public comment period at this point. So I'll just pause to see if there's anybody from the public who wants to comment. I think you have to press *6. Okay, not hearing any. We'll have another chance, I think, near the end of the meeting as well. But at this point, we get to take a break, which will last 5 minutes. And since it's 10:01, let's. Okay. Well, 10:01. Why don't we reconvene at 10:06? Take a 5-minute break, and we'll see you in a few minutes. Thank you, everyone.
make sure that if it doesn't go, usually it means that you have to adjust it on this, that couldn't connect the documents up.
Right, we should have everybody back. And the next thing we're going to talk about, thank you, is Cable's back to give us an update on the marketplace enrollees for 2022. Thanks, Cable.
No problem. Can everyone hear me? All right. So covering open enrollment for the 2022 plan year. As you can see in the first slide, we had 146,000 and change Oregonians enroll during open enrollment, which was the highest plan selection number since 2019's open enrollment. We had about 33,000 folks automatically re-enroll, and that is to say that they went in and didn't touch their application. Everything in their minds was good to go, and it just passively enrolled them into the same plan they were enrolled the year before. We had 83,000 folks who went in and took a look, maybe changed a little information, maybe shopped around. Whether or not they re-enrolled in the same plan or not, they did make some sort of change or on their information. And that was about 83,000 folks, like I said. So all told, we had about 126,000 or 116,000 folks come back in and auto enroll in some fashion. Then we had about 29,000 new enrollees, which is also a higher number than the last couple of years. You can see that most folks chose a bronze plan. However, silver was right there with it. And thanks to those cost sharing reductions for anybody below 200, 50% FPL, that's going to entice them into silver, and then a pretty good amount of gold enrollees too. Very few catastrophic enrollees, which has been the trend for the last, several open enrollments. Next slide, please. 79% of Oregonians who applied for financial assistance received premium tax credits. The average amount of the premium tax credit for folks who received them was $489. The average premium for folks who receive tax credits after the tax credits are applied is $130 a month. So a pretty big savings considering average plan premiums are usually $550 to $600. So that helps a lot. There's some other information on there about the total numbers. Cost sharing reductions, we saw 41,000 folks enroll in cost sharing reductions. And that's anyone with less than 250% FPL, like I said. Next slide. This year, and we can thank the ARPA tax subsidies, enhanced subsidies for this, we saw many more folks of the 400 and above percent FPL, federal poverty level, enroll in coverage. So on the right of the screen, you can see compared to 2021, the number of enrollees in those income levels for 2022. And that's been the biggest difference that we've seen since the ARPA subsidies came into play, is enrollees at that level, because with the 400% cap on subsidies, as well as enhanced subsidies for those.
Hey, Cable, we're losing your, can you check your volume again?
How about now?
That's good, thanks.
Okay. I guess I have to be right on this computer screen. So sorry for the close-up. Again, the ARPA subsidies, that's where we've seen the biggest impact, is those folks in the upper income levels. The removal of the 400% cap, as well as the increased amount of subsidies for those across all ranges, but really in that 250 to 400% FPL, it really took quite a chunk out of what people would be paying after tax credits. So that's obviously seen a major benefit to enrollees in the marketplace of all incomes, but especially those who were receiving marginal, if any, tax credits prior to the rule. Next slide. Here's just a breakdown of the different demographics of our enrollees: age, race, ethnicity, and rural, non-rural. As you can see, the majority of the marketplace enrollees continue to be in non-rural areas, which makes sense just due to the population spread, and where most people live is considered non-rural in Oregon. The age bands continue to remain kind of how they've played out for the last several open enrollments, with fewer younger enrollees, and as you tend to increase in age and insurance becomes something you think about a little more, you tend to enroll in insurance a little bit more. And so I know that Amy has worked really hard on trying to get those 26 to 35-year-olds to enroll in coverage with our creative marketing and outreach that we do. And the breakdown, as you can see, of the race, ethnicity, that's typically what we've seen every year. In our enrollments, it hasn't changed very much since 2016. Next slide. I guess that's it. Any questions about the, oh, I think I see a question. Yes, Holly, that is the one area where we did see a difference, was the Pacific Islander community. That number shrank significantly. I think from 900 to down to almost 200 with the COFA program, rolling into traditional Medicaid and allowing them to enroll in those Medicaid benefits. We did see a decrease there. That was the one area where we saw a decrease in the demographic over previous open enrollments.
Thanks, Cable. Mary Beth, you have a question?
Yeah, thanks. I just had a quick question about the APTC application speed. I think the slide said 79% of folks who applied for that assistance received it. Do we have any numbers about people who are eligible and didn't get it? Or didn't apply for it?
Well, there is roughly, let me pull up the number right now. So we had about 13,000 folks who didn't apply for financial assistance. They just went into the marketplace and purchased a plan. So those folks are excluded from that calculation. And then so 79% of the remaining folks were at an income level that made them receive premium tax credits. And there's a couple factors that go into that. First of all, if a plan is low enough cost, and you make a certain income, even if you're at, say, 300% FPL, you won't get a tax credit because it already falls within that affordability factor for you. And we see that with younger folks because of the way rating works. As far as who applied or who didn't apply and might be eligible, unfortunately, we don't have information that would tell us that. We get estimates from organizations around the country that help kind of, make estimates on that, but there's no real concrete data unless people reach out to us and tell us that information.
Thanks.
Great. Any other questions for Cable? I guess I'd be curious from the agents and the community partners if the data that was presented, anything surprise you, or does it feel about right, this open enrollment versus prior years? Looks like we do have a question or a comment from Holly. Okay.
And thank you, Cable, for addressing that comment. I was curious because we did help a lot of people come off the marketplace. So.
Yes.
And Cable, this is through February. Is that true? Open enrollment period.
January 15th.
January 15th. Yeah.
Yeah. And so this is all the plan selection numbers from that. It should be noted that these are not effectuated policy numbers, but the number of people who selected a plan. So that doesn't necessarily mean they paid their initial premium. And so the actual effectuated numbers will change a little bit from this.
Right.
And it looks like there's another question.
Yeah, Gladys, go ahead. Thanks.
Well, not so much a question, more of a comment that, yeah, it feels spot on. I did have some COFAs, not too many, but because they went to Oregon Health Plan. So that definitely, and I did have a lot more new enrollees this year than I had before. I mean, I felt it. It was like, oh my goodness, I was getting all these new individuals. So yeah, that sounds about right, that there were more this year than previous years. And I make sure that all my clients are touched. So I don't allow that auto enroll unless they don't respond back. And this year, everybody was responding back. So there was like nobody within my clients that I've helped before that did not respond. So I think they're more engaged in their plans. Not too many changed their plans, really. They stayed with what they were with. They just updated their income, which is the most important thing, so that they're not being hit with having to pay back part of that premium tax credit. So thanks for the numbers, because that really helps solidify what I was feeling this year, going, oh my goodness, this was a crazy year.
Yeah, thanks, Gladys, for confirming that. Before you go off mute, could you say anything about the new people that came on? Anything in particular about that?
I work a lot with the Hispanic community, and so it
froze up on us.
Or friends that say, hey, call Gladys, she can help you. So there was a larger number of Latinos enrolling, but I've had a good mix. Social media was a great way to bring in quite a few people. And I don't know what to do. And so then it's like, hey, talk to a broker. And sometimes it was through other people saying, hey, talk to Gladys, that they reached me, or because I was in the thread or I responded. So social media was a great way to reach people this year. I think more even than 2020. For whatever reason, I think people are more engaged and really are looking to make sure that they have coverage. That's the other thing, is that there were a lot more people saying, I just want to make sure I have coverage in case. So I have a lot more people on bronze plans than I had before. So having a good bronze plan that is meeting that need of getting to doctors, specialists, urgent care, generic medications has been great. And they are really excited about the addition of chiropractic and acupuncture to the list of coverages, which is something that a lot of times they would get a silver plan because that's the type of care they wanted. So those are some of the trends that I'm seeing that have been pretty important in the meeting the needs of what they need.
Thank you for your comments. Any other comments before we lose cable on this topic?
I should point out also that new enrollees doesn't include people who came in with the COVID SEP last year. So these are true new to this open enrollment enrollees. And so just to point that out.
Okay. Thank you for that. Hey, Don, do you mind going back a few slides? I just want to, maybe it's the first slide that Cable did. Oh, Mary Beth has a comment. Go ahead, Mary Beth. You're on mute.
Yep. The COVID enrollment actually brought up another question. Do we know how many people who enrolled during that special enrollment period are still enrolled or continue to enroll? Okay.
Yeah, unfortunately, we just get aggregate numbers, so we can't tell household to household if someone stayed enrolled. We just have the numbers, sadly.
Yeah, this is the slide I wanted to just mention before we leave this topic. I think what you were mentioning earlier is just the active re-enrollment. And, you know, I think I'm a little torn about making it easy for people just to re-enroll automatically, but we like to see the active re-enrollment. Is that what we're hearing? Because that means people are looking around and making sure they're getting the best. So before, I think Chicky, did you have something to say?
Yes, just to kind of wrap up, so this is how 2022 open enrollment looks like. We have quite the next few months of potential developments that will impact upcoming open enrollment for 2023. So for example, right, the federal public health emergency, if and when that ends in July, that will significantly impact our number of new enrollees, automatic re-enrollees, and active that will impact our general number overall. The bridge program, once and if implemented, that will also impact our enrollment numbers. Next slide, please, Dawn. So for the financial help, if the expanded tax credits are not extended, the 79% of Oregonians who applied for financial assistance received will most likely lower. So that's why there's a lot of advocates, statewide and nationwide, really advocating, really encouraging Congress to truly expand and extend these subsidies. And of course, the average amount of PTC for people receiving them, that will also change. So a lot of things are banking on the expansion of the subsidies. So we are definitely watching that. And then next slide, please. As you will see too, the two orange bars, the 401% and above, that has been significantly different this last year and a half. Because of course, again, ARPA subsidy. So that's another reason why we are encouraging the extension of the expanded subsidies. And last slide. And then the demographics of enrollees. CMS released some guidelines yesterday about their commitment to expand their health equity efforts. So we are going to be watching and working very closely with CMS and what that means for upcoming open enrollment. Because we would truly want to encourage more reporting, of course, that will help us a lot, as well as what other efforts and strategies they are looking to implement for the upcoming open enrollment. So that's just my way of saying our open enrollment, considering those continuous coverage requirements still ongoing, it's a very strong open enrollment. The team and I were very, very happy with 146,602 Oregonians signed up for open enrollment. But of course, there's a lot of things that are going to happen in the next couple of months that could impact, and we're watching that very, very closely. So this time next year, it will be good to compare how things are going, considering what could happen in the federal landscape. Thank you, Craig.
Oh, thank you. Great summary. And thank you, Cable, for all the great information. We're going to switch gears here to talk about the Marketplace Community Research. Kristin Lambert, she's the Senior Account Manager for Coats and Coats and Cokes.
Good morning, everyone. Let me just introduce myself really quick. My name is Kristin Lambert. I'm a senior account manager at Coats Cocos, and we are the agency that have been working with the marketplace in terms of doing some of the creative, doing some of the media relations, public relations. In the past, we've done some of the event management. And we are here today to kind of talk about some of the research considerations that we can do for the upcoming open enrollment campaign. I wanted to just introduce my teammate, Steve, if he's on here.
Yeah, hi Kristin, I'm here, and hello everybody. I'm Steve Cocos, Strategic Director at the agency, and I've worked with Kristin and of course Amy and Chicky and everybody on the communications work the last few years, and I'm thankful that we have this opportunity today to get your perspectives on how we can make the most of this research opportunity.
Yeah. So just a few things that we're going to kind of review today would be just some key takeaways. We won't spend too much time on those from the last open enrollment because it sounds like you all have been going through a lot of the numbers and kind of doing a deep dive into those. But what we're really excited to talk with you all today about is just kind of the research considerations and to get kind of your input and your feedback on what we think we need to know for the upcoming enrollment season. Next slide, please. Okay, so I think everybody's kind of seen some of these numbers already in this meeting, but just the overall, there was a 4% increase in the number of Oregonians who either signed up for coverage or re-enrolled in coverage through the marketplace. And just kind of from our end, in terms of some of the efforts that we did in terms of raising awareness, marketing efforts, we were really excited to see that 10% increase in new consumers who were able to enroll through the marketplace. Next slide, please. Thank you. This is just a slide that kind of shows the traffic. So a lot of our efforts for Coats Cocos was really about driving traffic to OregonHealthcare.gov and encouraging folks to go to the website to learn more information and to kind of really, take action. And you'll see that, this last year, the open enrollment period was extended. So we had more days that we needed to drive awareness and drive traffic to the site. And we were able to do it kind of with almost a similar budget as what we had last year. And with that same budget, we were able to actually increase the number of users who went to the website. And we were able to kind of keep a higher average per day number of users. So just kind of really showing that the efforts that we did, that Chicky and Amy's team did, really just worked in terms of just keeping a steady amount of awareness and traffic heading to the website for folks to enroll. Next slide, please. Thank you. So some of the key takeaways that we had, really just, we honed in our strategy for this last open enrollment campaign to really emphasize clicks to the website and also conversions. So less about watching the videos that we may have produced for the campaign, or other types of engagement. We were just really focused on people going to the website, and then once they were there, either taking action in that moment, or we were using a lot of retargeting efforts. So if someone landed on the OregonHealthcare.gov website and then clicked away, we were using retargeting efforts so that way they were seeing more ads on social, they were seeing OregonHealthcare.gov show up in more places to remind them. And then hopefully encourage them to head back to the website to either finish enrolling or finish maybe switching their plan up, since we did see a lot of active re-enrollees this year as well. Our efforts complemented a lot of the efforts that Chicky's and Amy's team did around mobile and text messaging campaigns. I know that was new this year. And we just saw a boost in that in terms of the number of folks who were coming to OregonHealthcare.gov from their mobile phones. And we just felt that that was really important, considering the fact that not everyone has access to laptops or desktops. For a lot of folks, you know, the only way that they can access websites, et cetera, is through mobile. And so just being a little bit more mindful of that and trying to meet people where they're at. And then just again, that 10% gain that we saw in new enrollees is just pretty incredible. Just considering, like we've already talked about, that more folks were able to have continuous coverage through Medicaid and OHP, and that there had also been a special enrollment period in which I believe we saw over 22,000 Oregonians who were able to enroll during that special enrollment period. So considering that more people could be on the Oregon Health Plan, more people had other opportunities or times of the year that they could enroll, to still see that 10% increase is just pretty impressive. Next slide, please. Okay, and so now Steve is going to talk about some of the considerations of why we're thinking of doing some primary audience research.
Thanks, Kristin. Yeah, exactly. This is kind of about why we haven't conducted primary research in a while, and since the world has changed in some significant ways since then. So I mean, I think that's definitely one reason. And the COVID-19 pandemic, has perhaps put an increased focus on healthcare and access to healthcare. So we think that there could be an opportunity there. And then also just the special enrollment periods and the things like bringing new people in. We have kind of a little bit of a new audience, or a new audience that's part of the fold here. And then with the administration as an active partner, it just seems like altogether this is a good opportunity, good moment to consider asking the audience some questions. But then it's kind of a question of, okay, well, which aspects of the audience, should we engage? We don't have an unlimited amount of funds for research. It's actually a fairly finite and focused effort. So maybe we can go to the next slide if that's okay. So there's a couple different ways anyway that we could approach it, and basically we could look at it as an acquisition strategy of how do we go get those last people that haven't yet signed up, even after everything that's been in front of them. Or we could look at this as a little bit more of a retention strategy where we can say, hey, there's quite a few new people that have come into the fold. Why don't we kind of talk to them about, what pushed them over the edge, what brought them in finally, and and then think about that in terms of retention. But even doing that could also become an acquisition, that could lead to an acquisition strategy, because you could set up the modeling for, okay, this is what brought the newest set of people in. Let's model that for the remaining sets. So anyway, and this is kind of the front end of it, where we're thinking about it from different angles. If some of you think that, hey, we're not even, neither of these is exactly the right way to be thinking about it, we're open to your input here about, how we should approach this. Structurally, we have enough resource for either a quantitative approach, probably an online survey that could be, pretty robust, 400 to 600 people, which would give us a pretty good take on some things. Or we could do, a kind of moderate set, I would say, of 3 or 4 focus groups to kind of get at more of the whys, why people are signing up, why they're not signing up. And so structurally, those are a couple of those are probably the two primary options structurally we could look at. I mean, if somebody has another thought, we're open to hearing that and discussing that, but that's what sort of rises to the top for us.
And then allocated 2 cities within the region based on.
I think we have
some
noise there. So Steve, do you want to take these questions as you go, or do you want to set them up and as you go through your presentation, address them?
Well, I mean, I think a discussion as we go. We've only got a few slides here, so I think if you've got questions right now, let's talk about them, and then our next slide basically throws out some starting points for what some of the questions could be, the line of questioning could be in the research. But if you've got thoughts related to the structural questions we've thrown out here, we'd love to hear them.
I think this would be a good time to get some feedback. People have some experience with this or have some thoughts. Please share them now. Paul has a question. Go ahead. And then
sure, and maybe not a question or necessarily helpful, but because I see a compelling argument for both acquisition and retention. On retention, particularly if we lose those additional subsidies, it would be really good to know why people are making the choice to stay, so that you could tailor communication and approach as people may face some external adjustments to sort of what the marketplace looks like to them. And then I'm come from an analytic background, so the quantitative feels nicer, more to dig into. But I am curious as we get to those next slides if there are some specific things we could get into with a qualitative approach and how that might, along the same lines as the retention strategy of really trying to understand how people are making these choices.
Thanks, Paul.
Good. Holly, you have a comment?
Yeah, thank you. Just a comment, and also to echo what Paul was just saying. I think, getting to the bottom of the why people are signing up, why they're not signing up, can really give us a sense of, what those strategies are moving forward to try and help, retain some folks and also bring in new folks. Just that comment, that's all. Thank you.
Yeah, thanks, Holly.
Any other input on this question, whether to focus on people who we've had trouble? Go ahead.
Yes, hi. Just the questions on the quantitative and qualitative, I think that's great for why people are signing up and why you stay. But I think another thing that I like to, I don't know, is part of your job or not, I want to know that, are they happy with the decision to sign up?
And I think if we talk to people who have recently signed up, that would be a line of questioning that we could explore, so.
Well, because there could be people who used to sign up and not coming back because there got to be something. Could be plan benefit, could be the confusions about the subsidy when they fire tax, they get to pay back, being penalized or something like that.
Yeah, I'm not sure. Go ahead, Kristin, go ahead.
Oh, I was going to say, that's a great observation, what happens once they sign up? What is their experience? I didn't get to catch the person's name, but someone was speaking right as I came on about more people signing up and wanting to have coverage just in case. And that being, a compelling thing, just having kind of almost the peace of mind or the assurance of having that coverage. And I think that's really interesting, you know, to know, and something that we could then explore a little bit as well, like how much the pandemic has shifted that mindset.
Mm-hmm. Yeah, for sure. We could do that. All right, so here's up on the screen now are just some of the questions that we've kind of been.
We do have one more comment here.
Oh, okay, great.
Lindsay?
Oh, sorry. I was mostly wondering how we could follow up with you more. I thought your presentation was done, so I just wanted to know how we can follow up with you more, because I'm thinking about the clients that I work with and how many reasons that they've talked to me about why they would want to sign up again, why they wouldn't sign up again, the situations in which what they're concerned about. And I think this is really, really interesting that you guys are doing this. And so I would love to have some more information about how we could continue.
Yeah, absolutely. And I mean, as far as the exact channel to get, I mean, we're glad to give out our email addresses and talk. We do, and of course I default to and defer to whatever Chicky and Amy say in terms of on that. But I know in our scope of work, we're planning on, we've got this conversation today, but we are planning on having a little series of interviews with stakeholders like yourselves, people who are, you know, who see how the rubber meets the road from a perspective like some of yours, you know, who work with clients, who actual people who sign up and know that. So we're planning on a series of those interviews as sort of our next step. So Lindsay, that would be perfect to have you included in the list. I mean, we don't have a list yet of people, but you know, just we want to get to people like yourselves for more in-depth conversations about what you're seeing, questions you may have, because in addition to this conversation where we have sort of a brief timeline today, and but then we're going to go about refining our approach through the interviews with the stakeholder interviews, if you will. Then we'll go to market in the research in one form or another. So the door is definitely open for that, and I'll defer to Chicky and Amy as far as how to get in touch with us.
Thank you.
So Lindsay and the rest of the HIMAC committee, so this is the first of many steps we will take in terms of how we approach the community research with the Toolkit. So please know more to come in terms of how to get involved. And at the very, very least, if you get super busy the next couple of months, you will definitely hear about the findings as we get ready for open enrollment, because the findings of the community research, whether we go the quantitative route, qualitative route, or both, will definitely inform how we run our outreach and education marketing campaigns for the upcoming open enrollment season. So definitely thank you, Lindsay, for raising the question and expressing interest. Please know we will be bugging you the next couple of months.
Steve, I promise we'll let you get to this slide, but I think we have one more question here from Holly.
Thank you. I just had a thought occur to me, and I know since Amy and Chicky are on the call, I was just kind of thinking about the community partner survey that we are often encouraged to use when we assist consumers. So just putting a plug out there that that might be a way just to kind of leverage the boots on the ground to collect some of this information, kind of just thinking about, would we incorporate some of these questions into that survey to gather information from those folks we are assisting with enrollments.
Okay. That makes sense. Okay. Thanks, Holly. Should we go ahead and move on, Craig?
Thank you. Yeah.
Okay. All right. Well, so just these are some examples of the things that have been occurring to Kristin and me as we've been thinking about this. But, you know, so understanding the mindset shifts that have occurred, you know, a lot relative to COVID, but, you know, how has it changed their view of healthcare and well-being? Is access more important now? It sounds like it might be. You know, that would be a line of questioning that we could pursue. is it what they're looking for specifically changing? Are there other issues that maybe we're not thinking about that are top of mind? But ultimately we are trying to get to the why are they signing up now for those who haven't, and then just like somebody else sort of said, how does it feel to have insurance for the first time? And was there a particular item that pushed you over the edge? And then trying to understand, okay, how important were these special provisions that have existed, so that with an eye towards trying to understand, well, what's likely to happen when and if they go away, and how can we, if not compensate for that, but how can we keep them enrolled, and how can we still get people involved when in an environment in the future where they don't exist. So those are just some sample thoughts, and we hope to embellish I think we've gotten some thoughts here today, and through the follow-up conversations with stakeholders, we're looking to, dimensionalize this and add to what we're trying to find out.
Right, Steve, maybe I'll react to that, and we have time for more comments, but I think what I'm hearing you say is, should we look at those people who've been on the sidelines and still are on the sidelines, or those people who recently come on board, I guess? That's one dimension. Is that sort of one question, and then the other is qualitative versus quantitative, where you have the focus group versus people filling out a survey, sort of directionally the questions you have here.
Those are ultimately questions that need to be answered through this effort. I think that in some ways the stakeholder interviews ahead of us, I don't know that this group has to make that decision, especially on the quantitative versus qualitative today, but we're definitely open to, what people's sense of it is, because qualitative's pretty good at getting to the why of something, yet quantitative is so much more robust in terms of the number of people you're engaging and all the specific, different demographics that you can touch on.
Well, I'm not an expert, but I'll offer an opinion. And I feel like looking at the people who recently have chosen to join the marketplace is a place to start. I think that may be most informative. If we keep pressing on the ones that have been outside, I feel like we probably have looked at that quite a bit. So it feels like that'd be more informative. And I think the questions you're asking about what's changed in the landscape are spot on. And you might be able to get more in-depth answers in sitting down and talking through that with people, more qualitative. But that's just my opinion on that. Looks like we have another comment too. Ines, please. Looks like you're on mute. There you go.
Still on mute.
Sorry about that. I'm one of the end users, and I find that every year I have completely different reasons for enrolling, re-enrolling. There are different variables that come in every year depending on what my health condition is at the time, bronze, silver, where I live has influenced things. So I'm of the mind that qualitative may not be so useful, because in 3 months from now, I'm going to have a completely different qualitative opinion as to why I'm here than I did, when I signed up for my plan in December. So I question how useful qualitative is. And I think there are as many reasons to sign up for this as there are people who sign up for it.
Okay. All right. Well, thank you.
Good. Any comments from people we haven't heard from this morning? I don't know if Andrew Stolfi, if you have some perspective from the insurance division, from some of your prior work on these sorts of things?
Yeah, I was just texting with Cheeky. I got distracted by a call and I'm trying to catch up. So sorry, just give me a moment and I might come back.
Okay, no problem. Ines, I assume you got your question answered, so.
Well, that was just input, yeah.
Input, yeah, okay. So you're good. Anyone else?
Does Om have a question?
Yes.
Oh, go ahead, please.
It's not a question, it's kind of curiosity that either quantitative or qualitative, how do you want the people to answer your questions? Is it coming to the multiple choices or they have to write? You know, because I deal with receiving emails asking for surveys. If everything take me more than 5 minutes, I'm done. That's just a comment. Yeah.
Yeah. Well, for sure. You know, there's a much more open-ended approach in qualitative, and we can go more in depth there. We can have some open-ended questions, and our research. I don't know, in our history with research, I think we find that we can keep people on for more than 5 minutes. You know, maybe 12. Maybe 13, something, you know, something more like that. You know, and there's also, if through online surveys, you can let people don't have to do it all at one sitting either necessarily if they don't want to. But yeah, to your point, we will have to have greater reliance on closed-ended, you know, multiple choice or ranking scale kinds of questions if we go the quantitative approach. That is true.
It looks like we have time for one more comment or question from Drew.
Thank you, Craig. I put it in the comment section or the chat section, but I do want to, I think it's worth a little amplification, which is asking about people why they signed up kind of feels a little bit like the same kind of surveys when people ask, are they happy with the car they purchased? When I think the state's going to be really well served to know for why are people who are staying on the sidelines. I think as I think we all are vested interest in like market stability, and I think that we'll gain a lot of value from knowing what more can we do to get those people on the sidelines into one of the various coverages, whether it be ACA or maybe they qualify for Medicaid or maybe there are other factors. But I don't think we have a great understanding today about why people are not purchasing, other than the obvious, which is cost. Well, that's a guess, because we don't really know. We're assuming it's cost.
Mm-hmm. Yeah. Well, I mean, this is the thing where we, you know, choices. We'll have to make choices at some level. I feel like we have a finite budget, and we could. I mean, I think it's interesting to focus there. And that's why I'm looking forward to having this conversation today and the follow-up conversations. In some of my experience, I will say that when you get down to the last, you know, few people who don't have insurance, so it can be hard. It can really be hard. I think what I've seen be more successful, honestly, is the approach but this is, my mind's not made up about this. I'm just saying, if you take the people who just signed up for the first time and look at what pushed them over and build a model around that, I have seen that kind of approach work before in informing things. But yeah, I mean, it would leave some questions. And if we do a quantitative approach, you know, we can actually get to a range of audiences a little bit more so than we can with qualitative. And there can be some range of audiences we deal with in qualitative, but so yeah, I mean, I appreciate the input, and I just wanted to provide some reaction that, you know, just what I've seen in communications and marketing is if you take successes and try to model them, we've had success doing that. And, you know, sometimes chasing the last 7 people who don't want to buy X or don't want to do Y can get hard.
Well, great. That's great question, Drew. I think you really highlighted some of the complication here. So I'm glad it's in your capable hands, and hopefully the feedback was helpful to both of you.
Absolutely.
Thank you for your time this morning. We are going to take another break. It's close to 10:55, just on the dot. So we'll come back together at 11 at this point. So see you then. Thanks again.
Thanks, everyone.
Hey, Chicky, you think we're ready for our next section? Great. All right, so next we're going to hear from Chicky and Victor about 2022 and 2023 planning.
Sounds good. Thank you, Craig. So for the next hour, hopefully less, because we do have a hard stop at noon. So this the 2022-2023 planning is really for planning for the Health Insurance Marketplace Advisory Committee. And most of you already know this, and I just wanted to formalize, and hopefully, Craig, at the end of this slide, if we can take a vote on the proposed HIMAC focus areas. Please know that these are not in order of priority, not in order of timing. They will probably all happen all at the same time. So all that to say, we have quite the scope of work for the next, really for the rest of the 2022 and possibly most likely bring over to 2023. So the 4 proposed HIMAC focus areas are Medicaid migration to the marketplace. This is, of course, in relation to the federal public health emergency unwinding, which is currently set to end in mid-July. The second would be the state-based marketplace transition. As many of you know already, that the HIMAC has recommended way back in 2019 that the Oregon Health Insurance Marketplace does begin transitioning away from healthcare.gov to becoming its own state-based marketplace. The third, of course, is alignment with the Oregon Health Policy Board as the newest committee of the board. There are some strategic alignment that we can and should do with the OHPD. And lastly is we, for our focus area would be to ensure the marketplace work is focused on health equity. So we are open to feedback, and if there is none, we would love to take a vote, a formal vote, and make this the official 4 focus areas for the HIMAC for 2022 and most likely 2023.
You want to take that vote now, or have some discussion first?
Well, let's do a discussion first, and then let's take a vote, depending on how the discussion goes.
Yeah, I think we have in the chat, Drew had a question, where, if at all, would the discussion about the bridge plan take place? Assume that's in the Medicaid migration to the marketplace. Is that covered under there, Chicky?
Sorry, I'm catching up a little bit. Can somebody read the question for me in the chat? My Teams froze and it's not showing the chat for me.
Okay, Drew's coming online. I'll let him ask that.
Thanks, Craig. And I hopefully not so asking so many questions to find myself getting kicked off the committee. But I'm asking the question, where within these areas would we have a conversation about the bridge plan and its impact on the insurance market? I'm actually not just thinking about the Medicaid migration, because current bridge plan proposals may also siphon lives away out of the individual market into a bridge plan. So I think that might be on the minds of everyone in this committee.
Drew, thank you for the question. So conversations about the bridge program will be covered by the Bridge Program Task Force. The first meeting for that is April 26th, and then the second meeting is May 10th. There is a task force that has been convened by the governor's office and appointed, I believe, with the legislature. We, as soon as the meeting announcement comes out, we will make it a habit of ours to forward it to the HIMAC in case you're interested. So just as a refresher, that is the task force. I believe it's 15 members from various members of the community, groups of the community, with an immediate deliverable, well, not immediate, but short-term deliverable of putting together a report to the legislature by September. So again, to reiterate the meeting cadence right now, the first and second meetings will be April 26th and then May 10th. As soon as we have that meeting announcement, we will share with the committee. But Drew, to your point, there will be impacts to the marketplace. Most of those conversations will happen at the Bridge Program Task Force meetings. And then anything else that needs to be brought over, we will figure out a way to bring it over to the HIMAC. We do have Lindsay Hopper as the HIMAC representative for the Bridge Program Task Force, and we will work with her very closely to see where it would be appropriate to bring Bridge Program Task Force topics over to the HIMAC.
Yeah, I think to your point though, Drew, as well, that I do think it falls under this Medicaid migration because that could take a number of forms, including the bridge plan. And I think that could have an impact on the stability of the marketplace. And I think that's where we, through Lindsay, would give that feedback and have that connection to that work. So that's how I see that.
And I also forgot to mention, Drew and Craig, Andrew Stolfi is also will be sitting on the Bridge Program Task Force as the Insurance Commissioner, as well as the Director of DCBS.
Any other feedback about these priority areas? Any comments? Mary Beth, please.
Yeah, I just have a quick question about the alignment with the Oregon Health Policy Board. Are there particular pieces that you're looking to align, or is it complete alignment? Or is there any piece that you can pull out for us?
Not at this time. I'm still working to digest the information from the Oregon Health Policy Board retreat that happened earlier this month. But of course, any recommendations on how we can better align with health equity, I think those are, of course, top of mind. They did mention a few deliverables in terms of how they would hope to synchronize with the different committees. So for example, maybe it's time to revisit our committee charter and see how best we can revamp that to make sure that we reflect current work. There's also talk about committee diversification, making sure that we have a diverse group of representatives in our committee. So fortunately for us, that's not an area that we have to make any more adjustments because we have a fantastic and diverse group of folks in our committee. So really, those are some of the things that I remember off the top of my head. There are a few things that I'm still waiting on additional information from OHPB staff, and we are going to look to figure out ways on how to best align with OHPB. So not full alignment because of course I believe they have some priority areas where they don't necessarily impact the individual market and may not be part of our scope of work. But there are some areas in terms of committee logistics and so on and so forth that I think would make sense for us.
Thanks, Mary Beth. Any other discussion about this topic before we take a vote? Okay, so Chicky, we want to take a formal vote, which I think requires a motion to adopt these 4 areas of focus for the HIMAC for the next year.
So moved.
I would say from 20, so we'll call, I'd love to have a first motion, a second motion, and then all in favor. And then of course, if we do have quorum, so I think that's not an issue for today. So may I please have a first motion to move it forward for approval?
And we had one from Ron.
Ron, thank you. Ron is a first motion, second motion, please.
This is Mary Beth, I'll second.
Thank you, Mary Beth. All in favor?
Aye.
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 In favor.
Aye.
Aye.
Thank you. I believe we caught that somehow, some way by the circles. Any nays? Okay, thank you very much. The 4 focus areas for 22 and most likely 23 are passed. Thank you, Craig. And I will pass it off to Victor, who will dive deeper into every single focus area. We have some questions, at least one question for you after every single slide. So, Victor.
Thanks, Chicky. And I just wanted to mention to the committee, so as we present this information, this is how we are viewing, how we're seeing this, but we're also looking for your input on these. So if either during each slide where we're discussing the focus area or at the end where we have the discussions, if there's anything you'd like to add or anything else we need to consider, I will probably talk about some things that aren't bullet points on some of these slides. So that's, we don't have everything in there. like on the slide, but we are considering a lot of different facets of these. But again, anything else you don't hear or anything else you want us to make sure we have considered it as we look at these focus areas, we're really seeking the committee's input on that for some direction. So we're going to start with the Medicaid migration to the marketplace. That is what we have taken to calling it, or 3M, as we like to abbreviate everything in state government. This is really intersecting with an overall OHA strategy to address the end of the public health emergency. Here at the first meeting where we have a lot of new members, I kind of struggle with how much background I should provide on some of these subjects, but for anybody kind of not aware, that just a broad overview, as we reach the end of the public health emergency, federally speaking, and that ends up changing a lot of the rules that apply to Medicaid eligibility, as well as many other things generally for like public welfare programs, that sort of thing. But what impacts us most directly is the rules for Medicaid eligibility. So as that happens, that means a lot of people that are on Medicaid, or which in Oregon is OHP, will come off. And we don't know how many, we don't know when exactly as those redeterminations go. So that's a lot of the planning that's being done right now. Our focus as the marketplace is for folks where they would go or end up after coming off of OHP after being redetermined as ineligible. So we understand that not everybody potentially falling into that category is going to be on the marketplace necessarily. There are lots of other places folks could go depending on why they're determined ineligible. They could have employer-sponsored coverage. They could be moving into Medicare. So there's a lot of different things that could happen there. So what we are doing, though, is like all of the other facets of state government that are involved, we know that if we don't start planning now, whatever solutions we come up with, we won't be able to implement if we start much later when we really need it. So so that's kind of the background on this this element. And what we are doing right now, what we're focusing on is first standing up a call center. The reason for that is we understand, depending again on how many folks exactly we're talking about, there's some estimates that range into the sort of 250,000 folks range, 250 to 300,000. Again, we don't know exactly how many to plan for, but as you may recall from cable slides, that's pretty much double the overall marketplace enrollment for any given year. So it's a lot of folks we're potentially planning for, and we want to increase the bandwidth we have to support folks with information or anything else they might need to find the coverage that's correct for them. So a call center contracting with an entity like a few different contracted call center options that we have seems to be the sort of quickest to implement. We have some experience already having helped to stand up the 211 call center for the vaccine project that OHA had rolled out. Our kind of background for a lot of folks in the marketplace, Misty Reyes is our outreach coordinator, or outreach and education manager. A lot of our outreach team have very strong call center background. So we're already making plans to put that in place, but also to hire on some limited duration folks to staff and manage that call center from both a contract management with whatever vendor is providing our call center service, as well as some additional folks for sort of more complex cases that maybe aren't as easily handled by a contractor. So so that's the kind of first element. There were some funds that were granted through House Bill 4035 in this past session, and that will allow us to have the extra funds to stand something like this up. And we'll be working again in conjunction with the other OHA entities that are kind of standing up similar things, but on the OHP side, to make sure that we're kind of aligned, but making it very clear that this is QHP or qualified health plan, health insurance marketplace plan work is separate and different from OHP work. And we really can't have those together at the same time. It's really asking too much of the people staffing those call centers to do both. So it really serves both communities or both sets of affected people better if those elements are dedicated to each. So so that's where we're going with that. Part of the what we're doing is working with the folks at OHA that had done the algorithm for the CCO 2.0 migration that was a few years ago. when OHP moved to CCO 2.0, it essentially meant a lot of people were going to be moved into different CCOs than they were currently in. And in order to do that most efficiently, they came up with an algorithm that looked at what providers they had in the current CCO that they were using, and if they had to be moved into a different one, which one would most closely match the providers they already had, so they didn't have to do too much moving of doctors, that sort of thing. So working from that sort of foundation, what could we do to repurpose that same algorithm to make a similar kind of match for folks coming off of OHP that have been redetermined ineligible? And what could we provide as a, walking that line between, we're not recommending best plan choice, but of the options that you have, this one most closely mirrors your provider network, if that's important to you. So something like that, to where we make the most obvious questions that people might ask when they're looking at which plans they want to go into kind of obvious to them. So here's one option, and so we've already made progress on that. It's basically been proven as a proof of concept. We've kind of got a few samples going. So when our call center gets up and running, we're looking at the planning for implementing that element to it, and hopefully, again, kind of streamlining and making choices easier to make for folks, depending on what's most important to them. Along with that understanding, also we have that network of community partners, insurance agents, and insurance carriers. They're all kind of stakeholders in this. Part of the reason for standing up the call center is, understanding that the bandwidth of the channels that people would normally use to enroll coming off of OHP are kind of limited in a certain respect. They're not designed to handle the potential loads of folks that will be coming off all at once. And so, in an effort to make sure we don't overburden partners by just referring everybody to just, find an agent, find a community partner, which works under normal circumstances most of the time. If that's just too many people for that network to handle, having another sort of place where people can call and actually get some assistance with that. So those are at least what we're seeing is the strengths and what we're building on as we make this planning for what we're now projecting to start at around October, perhaps, of this year, depending on when the PHE ends, depending on when the redeterminations start in earnest, and depending on the rate at which those redeterminations start coming out every month. So that's the planning that we're doing for that for now. The challenges that we're seeing, of course, is a workforce on many fronts. So we've got our own hiring that we need to do to make sure that we manage the call center properly. We need to make sure whoever we contract with is able to find enough people, because essentially this PHE unwinding, if you will, touches kind of many different facets, not just health insurance, not just Medicaid, but all sorts of different programs that may also need to staff up for this effort of their own. And so just finding the right people with the right qualifications, it makes it a much more competitive market and a much more competitive prospect. Along with that, the potential, depending on when this starts, for the member needing to enroll twice, depending on the timing of when the redetermination is made. So that's, again, if for all of you in the know already, if we start in, let's say, October, and people are able to enroll because of an SEP losing Medicaid, then they've enrolled essentially for the end of the year, and also have to re-enroll for the following year, because if you enroll at that time, it's a little too close to the open enrollment period to be eligible for the automatic re-enrollment mechanism that normally takes place there. So it's a difficult thing to explain to folks that don't know a lot about this stuff already, and have them sort of understand the implications of that. But that means that what's already going to be very complicated in some ways for folks coming off of Medicaid becomes even more complicated to try and help them understand, yes, you need to enroll now. And then when you enroll now, you also need to enroll again when the open enrollment period comes, to make sure you have coverage for next year as well. So we're discussing OHA potential strategies on ways we could mitigate that. We, again, don't know what the timing or the criteria that'll be used to redetermine folks, but because that also needs to be done equitably, we don't necessarily want to say, hold off on these folks and do these folks first or anything like that. That will end up being whatever method is used to redetermine folks, and the timing will end up being what it needs to be, and we'll need to react to that. And then lastly, the reliance on federal technology, healthcare.gov. This will be a recurring theme you'll hear through a lot of our stuff, and one that the committee has been looking at for a long time. So it's, as you all know, we use healthcare.gov for Oregonians to sign up with health insurance. It's not something we have any direct control over. As a state, we do have technically the authority to do a lot of the things with our state-based marketplace, but healthcare.gov is really the determining factor on whether or not they're actually done. So when people go to Enroll, that's where they go. Connected to that is the healthcare.gov call center, which again, for many of you in the community partner and agent community is kind of, can be a barrier sometimes to progress, especially if anything happens with the folks that you're working with that fall into like a complicated case category. Having them call or helping them call on their behalf can be a very long and drawn out process. And in this case, again, they're serving most states in the US. And so I want to say 37, probably a few less now that a few more states have come on, but it's the majority of states at the moment. And because they serve most states, we're not the only state that will be experiencing the end of the public health emergency. So we don't really know what their capacity looks like, what their ability to handle the call volumes or the kind of customer service levels we can expect at that time, which aren't always the best to begin with. So it's another variable we're having to plan around, and another kind of reason for us to staff up that call center that we're creating as well as we can to see if we can get people helped out as best we can without necessarily having to go to a healthcare.gov call center. Recognizing that in some instances that might be necessary, and making planning for that as well. So that's just a didn't seem like quick, but a quick overview of that particular focus area. Wondering if anybody has any questions there. And I don't know if I can see the hands very well, but glad to take any questions on that if you have them.
Yeah, Victor, this is Craig. Maybe, and I know you need to get through the rest of these, so I won't slow us down too much, but I think these are good, but per the comment from Drew earlier, and I'll just reinforce that, I think, part of our responsibility as a Marketplace Advisory Committee is to advise on affordability. So I think we do want to consider the impact of the Medicaid migration and how that's handled on the marketplace. But not just this feels a lot like the mechanics or the operations of that, but I think we want to also consider the impact of how, and maybe advise on that too.
And we can definitely approach that in whatever way the committee sees as best. We have this focus area, and then we also have the alignment with OHPV focus area, where really we feel the role of the HIMAC, and of course the HIMAC would need to agree, but would be sort of bringing the issues that are kind of more relevant to the private health insurance individual market to those groups that maybe don't deal with that as much. You get some of that with PEB-OEB, but for sure, as we look at this, one big factor, again, that's not listed here in the bullets, will be that bridge plan. What is the impact of the bridge plan? What does that do to our recommendations or the people we help or who we refer back to OHP if they've been redetermined ineligible but do qualify for the bridge plan, which we are not managing and is not directly under like healthcare.gov or the marketplace, making sure that they're getting the correct information and getting to the right place. But then at the same time, again, this is more operational as we, the marketplace staff, look at it, but as the committee looks at it, when we look at something like a bridge plan, that definitely has impacts to the individual market generally. What are they? What does that do to rates and kind of estimates, projections? It's a lot of fog of war right now that is difficult to penetrate. And we're trying to help each other out as much as we can with that data. So that's why I mentioned this project that we have, this Medicaid migration to the marketplace. It's really one project among many at OHA that are being managed as a portfolio for this effort for the PHE unwinding. So while plans are being made in other ways to prepare for that, our plan kind of integrates with those, and we're talking to each other where they overlap. When it comes to say market impacts of something like a bridge plan, that's actually a bit beyond what we have ability to control directly, but they are things that could be brought up to, let's say, that health policy board when the decision-making part of it is really considered. So yes, thank you, Craig. It's a difficult thing to fold to. I don't want the committee to feel like it has to put subjects into one category or another. So wherever it makes the most sense to talk about them, we're glad to speak about them in whatever context makes the most sense for the committee when they're talking about it.
Great. We'll let you keep going through these.
Okay, and yeah, I'll go ahead and take this one too. State-based marketplace transition. This is something I've been involved in for a while, and so does the committee. A lot of you that are new, just a quick primer, or as quick as I can make it. We, again, are on healthcare.gov. We've been kind of looking at other states that are making a transition to a completely state-based marketplace in which that state, instead of using healthcare.gov, gets its own enrollment technology and call center, and instead has direct control over the portal that their residents use to apply for individual health insurance through their marketplaces. So this has been a difficult thing to start a conversation on in Oregon because of what had happened previously with our first run at this in 2015 or 2014. So now that the landscape has changed, now that technology has changed, so many things have aligned in a way that is much more risk averse, like lower risk and kind of lower cost as options for states. That really looking at this more closely in 2018 and 2019, the HIMAC, or at the time the Marketplace Advisory Committee under DCBS, recommended that we start pursuing getting into a project that would get us to a state-based technology. So anyway, that's kind of a primer for that. So we are continuing that effort. As we're seeing with the unwinding of the public health emergency, there are a lot of things that could assist with that if we had our own technology. And so in proposing that, we have a lot of sort of evidence in our favor. We have 6 other recent SBN transition examples, among them Nevada, Pennsylvania, New Jersey, New Mexico. Virginia is on the way. So in all of these examples that we have so far, of the 6 that have gone most recently, no failures in any of those, and not to say they're problem free, but essentially for big technology projects that all end on like one day, which is the beginning of open enrollment, or kind of culminate and have a deliverable date of November 1st. None of them missed that date. Everybody went live as expected, and that has to do a lot with just the vendor market and who's doing it, and the fact that they kind of know most of the ins and outs, timelines, risks, and variables, just having done this kind of over and over again. They're repeatable things that can be done. So the projected outcomes, again, are kind of in our favor. Cost less, our consumers are better served. We increased the state's control over its state-based marketplace. There's kind of no real downsides to a successfully implemented project. And that successful is the key part of it there. And it along with that, it also aligns, or because of that, aligns with the long-term OHA goals for equity coverage and cost strategies, in that it would give us sort of direct control over marketplace levers to do things that we can't do right now, implement programs such as premium assistance program, or any kind of program where like you use that enrollment element, and then also now we're doing this extra thing using that enrollment data to enroll you in this other program, being able to track that program. All of those things we can do much faster if we had our own state-based marketplace technology. Challenges that implementing something like this is a long-term project, requires a sustained effort and support, and ensuring that we don't repeat mistakes of other recent state IT projects, the things that always come up in the news, and that really makes stakeholders and legislators and folks in charge afraid of granting permission to do something like this, basically demonstrating that we know enough about it and have made the correct preparations where that this isn't going to end up like those did. So that's kind of the I guess nutshell-ish version of that. There's a lot more to it. We've had a lot of documents too that we've got from the past that we can refer people to, but are there any questions about that? I did that kind of fast. Okay.
Not seeing any, Victor. Thank you.
Okay, next slide, please, Dawn. Alignment with the Oregon Health Policy Board. This is where probably would seek a good amount of input from the committee. Strengths we outlined are basically the kind of more obvious ones, which is that we have the we being the HIMAC, so you have the potential to bring better understanding of private insurance issues to public health discussions in a broader sense. And part of the way of doing that is participating perhaps in other subcommittees or other places where not only can we bring that perspective to those committees that maybe don't already have a good amount of it at the moment, but also bring perspectives back from those committees to the HIMAC, to things that the HIMAC may be discussing. So kind of getting a better sense of the sort of dynamic between public and private health insurance and what factors impact both, and which from one impacts the other, and what we may be able to recommend or discuss about it. Challenges are that obviously the components of public and private health plans don't really naturally align. It's one of the big problems we're facing with the 3M, the Medicaid migration effort, is just trying to connect people to the same kinds of plans or service or coverage that they are used to, and not having them align very well. And again, repeated theme, Marketplace has few direct levers to operationalize innovative solutions. So any ideas that we come up with that could use Marketplace mechanisms to inform them, or could use a Marketplace enrollment system to get people into a program, we basically don't have the option to do. Something like a bridge program or a public health option could have been much easier implemented through a state-based Marketplace, but again, because we don't control that, we don't have that option. So that's our kind of very basic idea of what this could be. Again, happy to take any additional input on where our alignment with the Health Policy Board. This will also include the initiatives that they have kind of prioritized. So things like health equity, and all of those things are kind of together with where the HIMAC is moving as well. So, but any recommendations, again, happy to take from the committee. And also understanding as time goes on, if these more ideas come up or more ideas change, these aren't, these are fluid things that can be added to over time. Okay. Next, and then as mentioned, making sure that our work is focused on health equity. OHA has a strategic vision to end health inequities in the state by 2030. I think I have that right. I should know this. So the HIMAC strengths that it has in its favor, Marketplace has a long history being rooted in the community, and that includes a long history of really even just the dynamic between members in these meetings has always been cordial, has always been respectful, has always been really hearing each other out and hearing each other's different perspectives. I think that's a really strong foundation to build from. There's never been any real any sort of conflict you'd see in a meeting, really just from the policy perspective and not really having to do with much else. But also just being rooted in the community itself, that participants don't always naturally speak state government speak, and really do have real perspectives from the different demographics, constituencies, cultures that they represent, and has always been very, very valuable to HIMAC. The diversity of the committee membership, as I just mentioned, will help inform that work. things that we definitely haven't thought of, or any perspectives that we may have lacked in the past with all this kind of new membership, will hopefully bring some new insights maybe that we didn't have before, and we're looking forward to wherever that leads. And then with some guidance from OHA and OHPB, they kind of provide the foundation for us to work from. So at least in terms of getting some things, some ideas kind of written out, and kind of a plan, a goal for us to pursue, gives us a good target to shoot for. And challenges, again, I guess this does come up, that we don't have a lot of direct levers to operationalize whatever ideas maybe come up with by the. So if we have some ideas to improve the equity of the marketplace, one place to start is usually data. Can we collect the data that we need to understand who's in the marketplace? Without really having our own technology, we don't have that. So that's a real crippling sort of, it hobbles what we can do if we don't have that data, or like where we have to start from. And then from there, what can we do to improve the equity? What can we change about maybe what's in the application or the application process? And those levers we don't have control over, so we'd have to either wait for healthcare.gov to implement that, or make sure we can implement our own. So those are just a kind of a quick overview. Any other input on what the committee might do to address the health equity element would be appreciated. So that kind of does, at least for the summaries of the focus areas, and then on to the general discussion. Any additional input you have, we're ready to hear.
Great, thanks, Victor. Any comments on this particular area of focus before we move on? I think my comment on this is, it seems like this area is related to some extent to having our own technology. So there's some overlap in these areas, as you pointed out earlier, Victor. Great.
This is where we took. Oh, go ahead, Chicky.
Right, because I know you took the bulk of the presentation, so let me take this one and give you a break. So for those, as Craig mentioned, there was a handful of HIMAC community members who were able to attend the Oregon Health Policy Board retreat in early April. And one of the questions that was posed over there that we wanted to bring over here to see if you have some initial input is, how might the Oregon Health Policy Board support the Health Insurance Marketplace Advisory Committee? So, for example, consideration of HIMAC input in matters impacting private individual health insurance. So obviously, right, the Bridge program, as we definitely need to provide input into that. Providing additional information or context on the board's work if needed and where applicable. And of course, lastly, opinions or input on equity-related issues. So for those, whether or not you've attended, you have additional thoughts. If at that time you took some notes and would love to share that in terms of how the board might be able to support the HIMAC and vice versa, we'd love to maybe spend a minute or so to get your input on that.
Paul has.
Paul, go ahead.
I guess, and I know it wasn't the focus, but it did strike me just how broad the OHPB scope is. Just the number of boards underneath it, the number of, just the span of healthcare and health-related issues that they're responsible for. And so some of it may be of, hey, we can't reasonably expect them to do like a lot of things directly for us, which is why I do like sort of the frame you have here of, yes, absolutely make sure we have an opportunity to share thoughts and ideas with them. Like just, as much of anything, giving us the opportunity to communicate with them, especially, I'm new to the board, but if we're all sort of new to this structure, just making sure all those touch points happen. Like we can't count on them necessarily, just given all the stuff they have.
Thank you, Paul. Sorry, I was a little delayed because I was writing down your feedback.
Holly looks like she has a comment.
I'm just trying to determine like what's the best way to state this. I'm thinking about accountability and just all of the really great discussion they had during the retreat about equity, and I think they should hold us accountable and point out any areas for improvement where we need to look at where we are not you know, equitable, I guess is what I'm trying to say. I would like to think that that might be just an accountability piece where they could give us feedback in ways that we could think about improving our approach to equity.
Okay, thank you, Holly. Any other feedback? Or even requests for additional information? I recognize, I mean, it has been a few weeks, but it only has been a few weeks. I mean, it really depends on how you want to look at it in terms of wrap up and debrief out of that. There's robust conversations during those 2-day retreats. So recognizing that I'm sure there's some missing information or there are gaps that we can fill in with some information and more to come. But if you have any specific pieces of information you'd like us to make sure we request and bring forward to HIMAC, we'd love to hear about this as well. And please know, if you can't think of it right now, this is not the end of the feedback loop. Of course, we can always email to and exchange thoughts and ideas that way. Okay, looking at the time, Craig, I think I will move on to the next slide if you're comfortable with that.
Yes.
Okay, so the team and I, we've been talking about between more than 50% of the committee being new members or even members that have just joined in the last 12 months. Between that and then our move over from the Department of Consumer and Business Services to the Oregon Health Authority, we truly feel like there's opportunity to really, for everybody, including ourselves, to learn more and do more. So we are thinking about, we are proposing that we incorporate into our regular meeting series, maybe an hour or less, depending on the topic, to introduce an education series. So for example, on July 21st, which is our next meeting, we would love to provide an overview on OHA's Equity Inclusion Program. So this is the program that Leanne Johnson is the head of. And of course, as we try to move towards more health equity strategies, alignment, so on and so forth, for us, it makes sense. We need to know more, right? What the overarching theme is. And then of course, July 21st, also we think in terms of timing, what is plan management? How does that work in terms of the marketplace? And how does that impact what we do here in the marketplace and what we're able to sell to Oregonians to make sure that they are covered? So that's for July 21st. And then October 13th, which is a few weeks before open enrollment starts, we'd love to give you a brief overview on what our partner agent program is, what our community partner program is, and small business health options program. How does that look like in Oregon and the small business tax credit? So these are just some of the primary topics. And of course, recognizing this is our baseline version. And you'll note we only have July 21st and October 13th topics identified at this time. And we'd love to hear from you. What would you like to know more about?
You'd like that feedback now, Chicky?
Yes, please. Sorry. I recognize I did pose it as a question, but I also had my presenter voice going. So what would you like to learn more about? Are there any topics you want us to consider including in the education series?
What falls under plan management, Chicky?
So plan management would be Katie Button's shop, her program, and she would cover things like what does she look for when she looks at plans and in partnership with the Division of Financial Regulation. How do plans make it to the marketplace? What do they look for to approve them to be sold for the upcoming open enrollment? What in terms of CSR variants, what are those? What are cost sharing reductions? What are the different levels of actuarial value plans, the different middle tiers? So it's really, it's probably, especially for our actuaries, this will probably be, this will be a refresher for you all, but it could be more in-depth for other folks. Our agents, I'm sure, are very, very familiar with what the different plans are on the marketplace, but can kind of like, it's an overview, but a little bit more in-depth on how we do it in the marketplace and how we get ready for the upcoming open enrollment season. I definitely do not want to go and dive into the math, the actuarial value of actuarial value math. That is very, very complicated. I don't think there's enough time to ever get expert on that. Like Craig, I think it's in 20 years, and I'm sure he's an expert by now, but I'm sure he'll also say it takes more than one session.
It'd be boring to people. Drew, do you want to make your comment? Looks like you raised your hand.
Sure. Thanks again, Craig. I think I might benefit. During the retreat, there was a lot of anecdotal data given about people's struggles with affordability with relationship to marketplace products. I'd love to actually see a little more quantitative data about Oregonians' difficulties in purchasing or ability to purchase products in our marketplace. The anecdotal evidence was definitely hit me, but I think as a committee, we want to be able to plan based on data, not on individual stories. So I don't know if that's available. It's not something I'm regularly familiar with. I could use benefit there.
Okay, thank you. I don't know off the top of my head if that data is available. I know we do have a resource in terms of the Oregon Health Insurance Survey, but I don't also remember when was the last time that was done. So yes, I hear you, and I think that gives us, the marketplace team, an opportunity to do some treasure hunting, and we'll get back to you in terms of timing of when we can incorporate that into the educational series.
Right, and it looks like we have a comment here too, Chicky, from Lindsay Hopper, and I think the nature of this, and she can jump in if I get this wrong, is not just do the education, but target it with some discussion questions as well. I think to get some engagement, I think is the nature of that, and even provide some feedback to the Oregon Health Policy Board.
Sounds good, and we will work to incorporate that as well. So either way, I think thank you for the positive feedback so far. I think we have enough for our next couple of meetings, especially since this will be in addition to our other topics. So kind of to give you a heads up of what we normally talk about, especially around the October timeframe, is really input on, we seek your feedback on our outreach and education campaigns and strategies and plans for outreach and education and marketing. July, I think, if I'm looking into my crystal ball clearly, hopefully we'll have some information on the federal public health emergency and how the 3M, the Medicaid migration to the marketplace, that will be huge for us, right? Especially if we need to start bringing folks onto the marketplace by October. So I think there's a lot of different topics, not currently set in stone, but in my crystal ball, I think we're going to be full of, we're not going to be lacking in topics. So this is in addition to our regular table of contents, if you will, for the next few months. So again, if you think of anything other after this meeting, would love to hear it by email too. So thank you so much for the feedback, everyone. So looking ahead, next slide, Ron, please. Okay, looking ahead, committee housekeeping. So at this time, we have 14 out of the 15 committee members. We have 2 committee members who are going up for reappointment and Senate confirmation in the June session. It was previously May, but the legislature, I think, moved it to June. And then we now only have one vacant seat, and this is the seat that was vacated by Sandy Sampson, who is our tribal representative. So we are actively recruiting for that, and also working with the Julie Johnson and the OHA's Tribal Affairs program to find the best representative for that. I know they brought that to the SB 770 meeting, and hopefully we'll have somebody for confirmation. If not, probably not in June, the June edition, but the one after that, which I'm thinking might be in September. So that's one quick update. We do have our elections of our committee chair and vice chair. I'm not putting anyone in the spot at this time, but if you're interested in serving as chair and vice chair for your current term, I would love to open this up in July. So I will send an email to the committee here shortly, kind of asking, hey, if you're interested, would love to know kind of really what if you're interested in any additional information you'd like to share with myself and the committee, and hopefully we'll be able to hold formal elections in our July 21st meeting. So that's first item for housekeeping. The next two items, really, I think it's really more on the marketplace team. We need to work on developing the committee charter, as mentioned at the Oregon Health Policy Board. So the team and I, we will look into developing that and sending you an advanced preview, hopefully to be able to vote on for the July 21st meeting. And then lastly, the committee work plan. So today's conversation really informed a lot of what's going to go into that. Please know it will be a baseline version, because things are always fluid in the world of health insurance, health policy in the marketplace. So we are hoping to provide you with the committee work plan. I don't believe this is something that we need to formally vote on, but of course we always love to have consensus, and we'll get this done through email through the next couple of weeks, hopefully definitely before the July 21st meeting. So these are some of HIMAC housekeeping looking ahead details. Did I miss anything? Okay, I saw none. So Craig, I will turn it back over to you.
Okay.
Next,
well,
Don.
We're nearing the end here. We have one more opportunity for public comment. I think you press *6. We tested that, it works. There may be a slight delay, so I'll give people a moment to do that.
Are you able to hear me?
Yes, thank you.
If we would like to serve on the committee, can you tell us what that involves? Is there training or no training, and how often would we have meetings?
Which committee are you referring to? This committee?
Yes,
Chicky, do you mind taking that?
I don't mind at all. First off, I'm a little delayed in figuring out, what's your name, please?
Aprilla McPherson.
Perla McPherson. So we will follow up with you directly. I believe we got your number here. Currently, we do not have any open seats available, but normally when there are available seats, we do send out email announcements about our upcoming vacancies, and there is a process for application that goes through the governor's office. So the Health Insurance Marketplace Advisory Committee is a governor appointed and Senate confirmed committee. So there are several layers that it goes through, but we love, thank you so much for interest in it. If I can follow, is your number 503, the 2701? The 270, okay. The
yes.
team and I would love to follow, because even though we don't have current vacant seats, we love public participation. So please know, we'd love to keep you in our distribution list to make sure that you get the invites, you get the information, if that's okay at this time.
That is perfectly fine. Thank you so much.
Thank you very much for your interest.
Mm-hmm.
And then, Craig, there was a question on chat. It's from Laura Beagle. Quick question: what is the proposed timeline for the state-based exchange transition? So Craig, I will answer that question as well.
Thank
At
you.
this time, the proposed timeline, it needs to go through the legislature. So there is a legislative concept that has been proposed that will need to be approved by the current governor and the upcoming governor to be posed and at the 2023 long session, which I believe starts in late January. So that's the current timeline. It needs to be approved. It's going to be a lengthy transition. We still need the green light first. First and foremost, we need the green light from the Oregon legislature. So we need to get that first, and the long session is our current mile marker for that. Thank you, Laura, for your question.
Good. Glad to see the public comments. Any others, either by phone or chat? Okay, well, let's move to the wrap up then. Good, so we're reaching the end of the meeting, and I just wanted to extend a great big thank you to everybody who participated today. I really do appreciate the engagement from all the committee members. I want to also extend an invitation to you all to give us feedback, both Chicky and to me. We're open to feedback, how we can, just your impressions about the meetings and how you'd like to see them in the future. So please don't be shy about that. And I also wanted to remind you all, Chicky sent out an email on, I think it was April 15th, House Bill 4035 also created a community partner work group. So anybody who's interested in joining that, if you haven't already responded to Chicky, or I guess you could apply directly to do that. But I think there's lots of ways to serve on this task force, not just the task force, but there's other avenues. And I think the community partner feedback would be very helpful there. And also, I say, in keeping with that theme, we heard earlier from Amy and Kokis about some of the work that they're doing. If you're at all interested in getting engaged in that from as a committee member, please reach out to Chicky. I think either one of those avenues you can be involved. So I think you have insights that might be helpful for that work. So I'd encourage you to do that. And then the last thing I'd like to say is we did hear about this family glitch fix and this public comment period. I don't think as a committee we make those kinds of comments, but I think either through your own organizations or you publicly, if you wanted to support that during that period, I'd encourage you to do that as well. So that's all I had. Chicky, you have anything else you would like to say in closing?
No other than please expect, I will try to keep my email traffic to you as minimal as possible, but no promises. There's a variety of different topics. Please, if you can't remember everything right now, please know that we will be following up via email and making sure you have it at the top of your inboxes, and hopefully we can move forward with the different deliverables and outputs that we just talked about today.
Okay. And thanks again to your staff.
Oh,
Chicky. Good.
Sorry, I am so sorry. I remembered one thing. So Craig and I, when we talked about HIMAC meetings a few weeks ago now, state buildings will be opening up to the public on May 1st. So we do have an opportunity to switch to hybrid meetings, and wanted to do a quick check with the committee if you would be interested in traveling to our new office, new to us, the Marketplace office on 500 Summer Street. Again, there will always be a dial-in option, a virtual meeting option, but we wanted to check in to see if you are all feeling comfortable. You don't have to answer this now. Again, it will be follow-up in email. For the July 21st, we are looking to maybe opening this up for in-person meetings. Personally, I am looking forward to that, but those are my personal feelings. I love in-person meetings more than virtual meetings, but please know we will have everything. Still, virtual meeting feature will be available.
Okay. The last thing I wanted to say was just thanks to your staff, Amy, Cable, Victor, Don, for putting together this meeting and the presentations. And with that, I think we can close today's meeting. Again, thanks everyone.
Thank you, everyone.
Thanks, everyone.
Good seeing you.
Thank you, Chicky.
Thank you. Have a good day.